Or good afternoon. Welcome everyone to our May edition of the Women in Diagnosis series of VMR. My name's Anna. I'm one of the members of the CP Solvers and very excited today to be discussing a case with my partner in crime, Dr. Smitha Ganeshan. And we have a great group of discussants, and we have an amazing case to share with you all. And we're just really excited that you all could be here to kind of celebrate this space that's kind of devoted specifically to elevating the voices of those who identify as women in the clinical reasoning environment. And we also would love to hear from you all, like either in the chat or afterwards. You can tell us if there are any initiatives that are going on at your home institutions that are something similar to this. We would love to connect over that. But without further ado, I am going to turn it over to my partner in crime, Smitha, so she can introduce herself, although needs no introduction, and then we'll have the rest of the crew introduce themselves before we kick the case off.
Amazing, Anna, thank you so much. It's always so fun, my favorite hour of the month, to get to discuss a case with you and to elevate the voices of women in medicine. And again, just like Anna said, if you're interested in this space, want to learn more about it, want to get involved, please do let us know. We're always looking for case presenters, for discussants, and just really enjoy getting to connect with you. Like Anna said, my name is Smitha. I'm a second-year resident at UCSF and a member of the clinical problem-solving team, and excited to be here. Outside of medicine, I like running, I like hiking. I'm actually currently on vacation in Hawaii doing a lot of all of those things, and it is 5:04 here. So excited to be with you all. And with that, I will pass it over to Asha Patel.
Yes. Hi, guys. My name's Asha Patel. I'm a second-year infectious disease fellow at University of Maryland Medical Center with a primary focus in transplant ID. So I'm really excited to join you guys. Thank you for welcoming me. Something outside of medicine that recently my husband and I have gotten involved with is we just applied for a Bernedoodle application. And so we're really excited to get a Bernedoodle puppy, hopefully in the next few weeks. So yeah, that's one of the things that I'm looking forward to for the summer.
That sounds amazing. We welcome all types of dog interesting facts. At the CP Solvers, dogs are the best. How about Sherry and Casey? Do you all want to introduce yourselves? Oh, Sherry, I don't know if we can hear you. I think not yet. How about while you troubleshoot, we'll come to Casey to introduce.
Hi, I'm Casey. I just finished up med school at Chapel Hill, actually with Sherry. We were co-MD PhD buddies together. So we both can finally call ourselves doctors. It's been a requirement for my family to do that for the last 2 weeks. I am going to stay on at Chapel Hill for internal medicine residency, and I'm interested in rheumatology ultimately. Something outside of medicine, I have anywhere from 14 to 20 pound cat, depends on how much food my husband feeds him, named Mango. He loves to sit on you and squish you so you can't breathe. That's what I do with most of my time, Netflix and the kitty.
That sounds awesome. Maybe we can go to Sherry to see. I think there still might be an audio issue. Sherry, you could try leaving the meeting and we can let you back in, and maybe connecting by phone, I think. Oh. Yes, there is an echo, but we
because
can hear you.
I'm using both my laptop and my cell phone. Sorry about that.
Oh, that's fine. This is
Sure.
actually perfect.
My name is Sherry. As Casey said, I'm just graduating from University of North Carolina, and I'll be joining UCSS for internal medicine. Super excited to be here and discuss the case with you all. Something outside of medicine. So first fun fact, I'm actually in my closet right now because I'm moving today to the West Coast. So super excited. And I have a 4-year-old bearded dragon. Her name is Toothless, and she just laid 24 eggs 2 days ago, unfertilized eggs.
That is so cool, Sherry. I'm also very curious, once you get out to the West Coast, you'll have to tell me what the process of moving with a bearded dragon is like. I can imagine technically difficult.
Yeah, definitely.
Very cool. Well, I think with what we can go ahead and do is maybe, Sherry, if you and I want to partner up, and then Smitha and Casey, you all can partner up. And then do you have a preference on whether you take the first or the second aliquot? Okay, Sherry, do you want to take the first aliquot with me, and then Smitha and Casey can do the second? And Ashka, how many aliquots total are in the case?
Ashka, I think you're muted.
Oh.
There are 4.
Okay, perfect. All right, that sounds great. All right, well, I will put myself on mute, and you can feel free to take it away. And just a reminder to just to speak slower than you would normally, just so we can keep up with our scribing.
Okay. So I'm going to present a 66-year-old female who was admitted as a transfer from a neighboring hospital for acute hypoxic respiratory failure. She presented with shortness of breath that had been progressive over 3 weeks. Prior to presentation, she primarily noticed Dysmeon Exertion for the past week. She noticed the dyspnea had been getting worse, and it was associated with a dry cough. And she also attests to increased weakness, but a review of systems is otherwise negative.
Amazing. And does that bring us to the end of our first aliquot?
That does.
Perfect. All right, Sherry, a fairly maybe common, a common chief concern that we see. Tell me how you're thinking about this.
Yes, thank you for this interesting information. So we have a middle to more senior year-old female who presents with dyspnea on exertion. And this make me think about focusing more on the cardio and pulmonary system, anything that can be wrong with that, and with the acute hypoxic respiratory failure. So thinking about the lungs, and this is a chronic problem going on for 3 weeks. So things on my differential are anything that can involve the lung parenchymas or anything involving the airway. And because this patient is more elderly, I will think more about malignancy. So things like lung cancer that can be going on, especially with the associated weakness that's going on. And other things that can cause hypoxic respiratory failure in the pulmonary systems are like vascular causes, like if this patient has a chronic pulmonary embolism or even any kinds of autoimmune disease like vasculitis that can also cause hypoxic respiratory failure. And for the cardio system, this patient, I would like to know more about her vascular risk for any kinds of, for example, heart failure in that line that can cause respiratory failure. So those are my thoughts right now. And this patient also have a dry cough that maybe makes pulmonary system more likely than cardio, although this is dry, not like productive cough. So I don't think it can help us make much more progress at this point.
Sherry, that was so excellent. I really don't have anything to add. I loved how you took the complaint the patient has of shortness of breath, and then you use the fact that she is hypoxic to really like hone in on the pulmonary system and whether or not it's cardiac in origin or a primary pulmonary process. There's clearly something going on in the lungs that is contributing to her hypoxia. So I thought that that was so excellent, but certainly, you know, we're still going to have our antennae up for other causes of Dysmeon exertion that could be contributory, things like anemia, things like a metabolic process, and then even like psychological causes of dyspnea. But I thought the way that you use that piece of information to arrive at a cardiopulmonary process was so excellent. And then the other piece that I really liked was that within the pulmonary system, you kind of like broke it down into buckets. Like, is this a parenchymal problem? Like within the alveoli, is this an interstitial process? Is this going to be a vascular process? And kind of looking at the different parts of the lungs. And I guess the only other one we should mention is like an airway process. And then kind of thinking about the lungs anatomically to dissect different pulmonary processes, I think is a really helpful way just to make sure we're ticking all of our boxes. And the reason why I think that is especially important is because this is a patient who's being transferred from a neighboring hospital. And so chances are this patient has already come with like a really, really complete workup. So I think being really meticulous and systematic about, okay, what could be going wrong, and really like creating a really good differential in kind of all of these different buckets is key to make sure that we're being really thoughtful and not necessarily like repeating tests that have already been done, but also like thinking about the whole spectrum of diseases that could be contributing to this patient's presentation. And I think the only like last piece of information that I will add is that it sounds like this has been, you know, more of a subacute process that's been going on for the past several weeks. And certainly, you know, depending on the host that we're dealing with, their underlying comorbidities, it does help us, I think, rule out like some really common causes of like shortness of breath. Like maybe you have like a bronchitis or something like that. The normal host probably wouldn't be short of breath for like a whole 3-week period. And so I think, you know, once we get more information about the patient's past medical history and maybe a little bit about their outside hospital course, we'll be able to be really thoughtful in thinking about like the whole, maybe even like layering on kind of like our IMAID mnemonic, even though we haven't necessarily gotten signal for inflammation. I think it's like just a helpful mnemonic to think about a whole spectrum of disease processes that could impact the cardiopulmonary system. Things like subacute infections. I love that you brought up malignancy, certainly autoimmune causes. And then, yeah, those are my thoughts. Do you have anything to add before we turn it back over to Ashka for more information? Alrighty, Ashka, back to you.
Her medical history is as follows. Aortic stenosis status post-TEVAR in February 2018, rheumatoid arthritis with anti-synthetase syndrome, complicated with polymyositis, treated initially with IVIG, then pulse dose steroids and Rituxan, and then finally switched to Cellcept in December 2014 due to an ILD flare. She is currently not on medications for this. She does have ILD, status post a single left lung organ transplant in September 2018, no induction. She's CMV donor positive, recipient negative, and EBV donor positive, recipient positive. Her transplant was complicated with an episode of acute rejection in April 2019, which she got prednisone for, and is currently on prednisone with cyclosporin immunosuppression. In terms of her PCP prophylaxis for her transplant, her Bactrim was held due to decreased renal function. The patient could not afford a 12-cone, and Dapsone was held due to leukopenia. She had finished her CMV prophylaxis with valganciclovir in February 2021, and her fungal prophylaxis with voriconazole and inhaled amphotericin B had finished in December 2018. She also has CKD stage 4. Her baseline creatinine is 2.5 to 3, secondary to calcineurin toxicity, Sjogren's syndrome, and hypertension. Her social history is that she's married, she does not use tobacco, alcohol, illicit drugs, and she has no pets. Family history is that her father had a stroke in the past and her mother had lung cancer. Medications are as follows. Cyclosporin, she takes 25 milligrams BID in the morning and 50 milligrams BID in the evening. Cyclosporin inhaled 3 times per week. Prednisone 5 milligrams daily. Atorvastatin 40 milligrams daily. Omeprazole 40 milligrams daily. Aspirin 81 milligrams daily. And nifedipine 30 milligrams daily.
Amazing. Ashka, is that the end of the second aliquot?
Yes.
Excellent. Casey, so much rich past medical history here.
I should have fought harder to go first.
I know. I am right there with you and was thinking the exact same thing. What is standing out to you here, and how is this second aliquot sort of changing how you're thinking about the patient's presentation?
So, I mean, it makes me a lot more just worried in general for her. Like, she has everything under the sun in terms of past medical history. I think, at least in my mind, from what I was able to actually even absorb in that like slew of information that came out, there was a lot of past medical history there. Some things that could be more likely, like, is this a flare of her ILD? She has a history of autoimmune disease and already lung disease, including a lung transplant. So is this just a repeat episode of that? She is obviously immunocompromised host, so I think infection comes really high up on the list, especially a lot of the prophylaxis stuff went really quickly, but it sounds like some of them have finished and she might not be being covered for all of the stuff still, and is on a daily prednisone and is most certainly an immunocompromised host. Some other stuff though with her like chronic kidney disease, like she's not dialysis, but like, is this like a renal pulmonary syndrome type of thing? Is she volume overloaded? What else did I grab? She has like, I mean, medicine for GERD. So like, did she aspirate? Like this essentially, I think both narrows and also opens up all of the things. Yeah, it would take me like probably a good 2 or 3 minutes to like really read through all of these past medical histories and think about them all in buckets. But I'd say probably my biggest ones would be like, is this a repeat flare for autoimmune disease, or more likely probably, is this an infectious thing, something like PJP or an opportunistic infection? I would probably want to make sure that I kind of go down both of those routes first. Yeah.
Casey, I love that. That was so expert. And basically, I think you did exactly what we can do here, which is to just say, this is an immunocompromised host with a million different things that could relate to her current presentation or could influence the way that she is presenting with this current presentation. And you essentially held up every piece of past medical history to this acute or subacute, acute on subacute presentation and said, could this be related? And every time you did that, the answer was yes, right? So aortic stenosis status post TAVR, is this a complication with the valve? And now she's in florid heart failure. Has she developed endocarditis? And now, she has a flail leaflet, and this is an infectious presentation. And the cardiopulmonary syndrome is actually just a complication of an issue with the valve. When you hold up sort of the autoimmune things, is this just common things being common, her ILD flaring up again? Or is this actually a hypersensitivity pneumonitis from medical or meds toxicity? When we think about her being status post transplant, is this an infectious complication, or any of the numerous non-infectious complications, including, as you mentioned, rejection? She's already had rejection in the past. She's had her medications changed a number of times, particularly with patients who are taking so many different kinds of medications with many different changes. Is she's taking her medications appropriately, particularly her immunosuppressants, and could that predispose her to rejection? And then thinking about other complications like, arrhythmias, pneumothorax, VTE, so all the non-infectious complications that could come about because of her immunocompromised state and her her being status post-transplant. And so essentially everything is on the table exactly as you said. And I think we need a lot more, the exam is going to be a lot more helpful, and getting some initial data will also help us, I think, narrow. But I think just as Anna and Sherry mentioned with that IMAID pneumonitis. So I'd want some basic labs. I'd want some cardiopulmonary imaging. So probably with an echo and a CT of her chest. And then we could probably go from there, and kind of getting a sense of how bad is her ILD to begin with can be really helpful. And then some functional assessments like a 6-minute walk test can also be really helpful. And then my other thought would be just with the ILD and kind of right heart failure, thinking about, right heart failure can be really challenging to manage. And so making sure that we're tracking management alongside diagnosis is going to be really important, particularly for this very sick patient. I'll pause there. Casey, anything else to add, or things that came up for you?
The only other thing is, like, just still keep things like PE and stuff like that on the table. This lady has, autoimmune diseases. She has a great reason to be hypercoagulable too. But I mean,
Absolutely.
like, literally, I think everything is on the differential for her until we get some more information.
Absolutely. And then thinking about, like, is this acute process related to this, what's been going on for the last 3 weeks, or was this completely separate? So was the last 3 weeks just a brewing ILD flare, and actually this acute hypoxic failure is a separate insult? And thinking about how those two relate to each other. So yes, all of the common things being both common and fair game, and then all of the uncommon things being on the table as well, including a very vast infectious disease differential that I will hold off for right now, but I'm sure we'll get there.
All right, so then I will move on to the physical exam. So on exam, her vital signs are blood pressure 144/86. Her heart rate was 114. She was febrile at 101, and her SpO2 was 86% on room air. So she required high flow with FiO2 of 65 and a flow rate of 35. The most significant things on exam is when you look at her, she is in respiratory distress. She is tachycardic, and on her lung exam, she has rales. Her abdominal was soft, bowel sounds were normal. She had no distension, no tenderness. And in terms of her musculoskeletal exam, she really had no sort of edema in her lower extremities, nor did she have any sort of joint pains or anything like that. She was alert and oriented to person, place, and time. Her skin was warm, dry. She had no noted rashes, and she wasn't diaphoretic, no pallor, and her mood, memory, affect, and judgment were normal. In terms of her initial labs, her white blood cell count was 15. Her hemoglobin was 9.6. Her platelets were 482. Her sodium level was 130, potassium was 4.4, and essentially everything else was normal. Her BUN was 19 and her creatinine was 2.04. Her hepatic functional panel was normal except for her albumin, which was 3.5. She had no protein gap. She did have a lactate that was 2.2. Her troponin was 21 and her proBNP was 387. They took a cyclosporin level, which was 67, and her CK total was 70. Her LDH was 919. And they did do ABG, so her pH was 7.45, her PCO2 was 30, her PO2 was 64, and she had an AA gradient of 212. On her initial imaging, she did have a chest X-ray with increased opacities in the right mid to upper lung with improved opacities in the left lung base. She had few hazy opacities in the left mid lung with areas of bronchiectasis. Right lung volume loss again appreciated, and her cardiac silhouette was enlarged. There was a transaortic stent valve in place and surgical clips the right upper quadrant, and she had no lines or tubes. And that's the end of the third aliquot.
Awesome. Thank you so much, Ashka. And I presume there's this aliquot, then one more aliquot, and then the final diagnosis?
That is
Cool.
correct. Yes.
Okay, sweet. Well, Sherry, a lot of really rich information. And also if there are things that came up for you when we learned about the patient's past medical history, layering that onto her physical exam, you can also feel free to share that. But how does some of this new information kind of frame how sick the patient is to you? And is it helping you at all in terms of where your diagnostic needle is swaying?
Thank you so much for this super rich information. I'm still trying to digest all of this, but just looking at the vitals, this patient looks pretty sick to me. So I'm pretty worried about this patient, especially with the oxygen of 86 and requiring a FiO2 of 65. And I don't know if we have the heart rate, but the patient is febrile with the temperature 101. So that makes me think more of the patient is inflamed. And given the background of the immunosuppressive state, I'm worried about any kinds of infections that might be going on in this patient. Let's see. And in terms of the rest of the exams, the pulmonary exam is helpful in that there's routes and help us localize more to the pulmonary systems. And the extremity exams, there's no edema in the lower extremity, makes me worry less about the cardio system. And in terms of the labs, it's very interesting. So this patient has leukocytosis. We don't have the differential at this point, but a white count of 15 makes me worry more about infectious etiology. And with the hemoglobin of 9.6, this can be, because this patient has so many comorbidities, this can be a chronic anemia or anything else. And with the platelet that's slightly elevated, that's also consistent with some kind of chronic inflammatory process that's been going on in this patient. And for the chemistry labs, so what jumps up to me is the creatinine is 2. That's elevated. We don't have a baseline at this point, but it might be related to this acute illness. And there's so many other labs that's interesting. So for the ABG, this patient is definitely hypoxic with the elevated AA gradient. So that makes us worry about the lung process and the pulmonary process. And the LDH is elevated. I know in pneumonia, sometimes you can get increased LDH. Another thing I'm thinking about is a PJP pneumocystic that might be on the differential, especially given that this patient is on prednisone. We don't know the doses for the prednisone, and seems like this patient is not on prophylaxis. So that just raised my radar for PJP. And in terms of the imaging, we see an increased opacity in the right. So there's a focal process that's going on, and the cardiac cilia is enlarged, but it might be related to the previous TAVR procedure. So in summary, I think this imaging makes me worry more about the infection that's going on in the lung. And because this patient is immunocompromised, I will do a very thorough ID workup to look for the organisms, and especially looking for we don't have an HIV status. We'll check for that and test for PJP and maybe other fungal infection that might be causing this presentation.
Sherry, that was so so complete, and I think I appreciate that you went through all of the different findings that we got for this patient, because I agree, like, while the differential is still so broad because it's an immunocompromised host, I think we're really starting to get There's a very strong signal for this being a primary pulmonary process. One of the things that I thought was really helpful is that we heard about like the rest of the patient's physical exam. And when I'm thinking about, potentially an infectious etiology for the pulmonary complaints that the patient has, I worry about it being a disseminated infection. And so being able to, use our physical exam to see if the patient has any right upper quadrant tenderness, to try to get a signal if there's any hepatitis or if there's any dermatologic findings that also might help guide our differential diagnosis. And it really didn't seem like there was much. What I don't know, because I haven't taken care of enough patients who have had a complex transplant history like this, is if their degree of immunosuppression can kind of mask findings on exam. Maybe not so much like dermatologic findings, but like any type of like intra-abdominal pathology. I think classically we're taught that, especially with prednisone, you can mask findings of both parietal and visceral inflammation. So certainly I agree with you that we'll want to be very complete with our workup, but we at least didn't get any like signal up front, and especially with there being normal LFTs, maybe the liver wouldn't necessarily be involved. But I think that that's just a really helpful thing to do, to just like use the rest of the physical exam to see if there could be any type of localization. Because if we had like pulmonary plus like dermatologic, or pulmonary plus like renal insult, and I think this patient has CKD, so maybe their creatinine isn't super elevated, but using other systems I think is a helpful thing that we do. One of the other things that I noticed about the imaging is that it appears that like at least the bulk of the parenchymal problem doesn't seem to involve the transplanted lung. It appears to affect like the non-transplanted lung. And to be honest, I don't know how that frames our differential at this point, aside from maybe suggesting that like that rejection might not be as much on the table. Well, I have no idea how to interpret the patient's cyclosporin level, so I don't know if that's therapeutic, subtherapeutic, super therapeutic. I may be thinking that based off of this being a predominantly right-sided process, maybe rejection's a little bit less likely. But I think everything else that you mentioned is still very much on the table, especially thinking about things like infection. There's a whole litany of infections that I hope Ashka can teach us about after the case is over. Pulmonary infections in patients that are severely immunocompromised. So like in our like viral category, I think about things like HSV pneumonitis. I think about things like VZV, CMV pneumonitis. This patient appears to have been on prophylaxis according to the past medical history, but would be at like especially high risk for something like CMV pneumonitis, given that the donor is positive and the recipient's negative. But I don't actually see prophylaxis on their medication list. So maybe they hadn't been taking it recently. In our like bacterial category, I think we can think about like our whole kind of bucket of typical bacterial organisms that would cause pulmonary infections. But then I think like there's like a whole bunch of like atypical infections, like the ELAs and whatnot, that can cause more of like a subacute inflammatory pulmonary syndrome. And maybe learning a little bit about the patient's exposures and whatnot might be helpful in deciding if those types of things are on or off the table. Certainly mycobacterial infections as well. Having never taken care of a patient with like disseminated mycobacterial disease, I don't know if like the classic finding would be this type of kind of like diffuse opacity that we see on imaging. But perhaps like a miliary distribution could look this way on a chest x-ray, but definitely a high-res CT would be more helpful. And then the last two categories I think about are fungal infections, which definitely would be on the table. It sounds like this patient has been on voriconazole in the past. I don't know if there are any gaps in voriconazole from a prophylaxis standpoint. or if there's like any resistance patterns in certain areas of the country. But certainly I would be suspicious about endemic mycoses. And then parasitic infections, I think would be very, very unusual. But the one I often think of is like strongy. But again, I don't think that this like pattern that we see on chest x-ray is very typical. And then outside of infections, thinking about this patient has been on a whole host of medications that that can cause pulmonary insult, and like an array of pulmonary insults. So like a pneumonitis picture, effusions. A really helpful website I like to use is something called Pneumotox, and I just like type in the name of the medication and it tells me everything that can happen to the lungs. And so I would be going through this patient's medication list and just typing those in to see if there's kind of any signal there for medications that we would be suspicious of. And yeah, those are, I think I'll stop there. In terms of like next steps of data, I mean, I think getting more advanced imaging would be helpful, cross-sectional imaging of the patient's chest. It seems like most of the kind of pathology is localizing there, but I think if, you know, doing a pan scan also would not be a bad idea, just because we're trying to see if there's any other signal in other parts of the body. And then the other thing that I'm keeping in mind is that this patient's in significant respiratory distress. They're on high flow nasal cannula, which is kind of unfortunate because I think a really helpful study for this patient would be a bronchoscopy to actually try to get microbiologic data, but also evaluate for other things like DAH and whatnot. I think the patient is now outside of the window to do at least a bronchoscopy in the absence of being intubated, but I think ideally that would be a very helpful test. I think in the meantime, though, we could just start with getting like some sputum studies, some like expectorated sputum studies, because that has, I'm trying to actually remember, I think the sensitivity is I'm speaking specifically about PCP. I don't think the sensitivity of the expectorated sputum studies are as good in immunocompromised hosts that don't have HIV as compared to patients that do have HIV, but I think it would be a good place to start because it seems like this patient is not heading in the right direction. I'm actually going to ask Smitha and Casey if you all had any other thoughts maybe before we hear the last bit of information.
Casey, anything else that came to mind?
I don't think so. I mean, I think her trope and her BNP are elevated secondary to like lung-based strain on the heart, more like the type 2 MI. But that's something to also still just keep in the back of your mind. Like, is this all being driven by cardiac? It doesn't fit, but just like those numbers aren't awesome to see.
Absolutely. I totally agree with you. And Anna, I don't really have much to add. The only other thing that came to mind was this history of antisynthetase syndrome. And just keeping in mind that patients with certain serologies, like the MDA, I think it's the MDA5, can like really, with any small insult, like it can precipitate a really bad ILD flare, and they can actually like pass very quickly. And so just making sure that we're also tracking that, and, you know, will this patient need to be intubated in short order?
Okay, so with that, I'll give you the last bit of information. I did want to touch base. Someone had asked about her baseline creatinine, so that's 2.5 to 3. And with that, we have initial micro. She had blood cultures that were no growth. She had an RVP that was negative, a SARS-CoV-2 PCR nasal swab. She had 2, one at the neighboring hospital and one at this hospital, and they were both negative. Not to mention she had gotten both of her vaccinations. She had a urine strep antigen, which was negative, and a urine Legionella antigen, which was negative. Her beta D glucan was greater than 500. Her CMV DNA PCR was not detected. Her EBV DNA PCR was not detected. During her transplant infectious workup, pre-transplant infectious workup, she did have a TB quant gold, which was negative. And again, this was in 2018, and she did have an HIV test, which was negative. She did get a CT chest without contrast, and it shows diffuse ground glass opacities involving all 5 lobes suspicious for widespread infection. Bilateral pleural effusions are also observed, likely parapneumonic. Status post left lung transplant with additional band-like atelectasis at the right lung base. Persistent parenchymal fibrosis in the native right lung. Status post transcatheter aortic valve repair and scattered coronary artery calcification stable, no interval change in post-surgical appearance of the paraesophageal hernial repair. She also had an echo, which was largely normal. She had a dilated left atrium, no effusions, normal RV, normal LV size. And I'll stop right there.
Did we have an RVSP on the echo and how it compared to her prior?
So I can read you, I don't have a prior, but there is a bioprosthetic aortic valve with a mean gradient of 22. She did have mild regurgitation. She had a mitral annular calcification with mild transvalvular gradient and trace regurgitation.
Great, thank you. Casey, so much data here. I always feel like a little tachycardic and overwhelmed when I get a lot of data. And so I'm curious how you're feeling, and with this new data, kind of how this advances your thinking diagnostically.
Well, I think it nicely rules out a lot of infections. So that's helpful. Like a lot of stuff was negative. So you can start crossing stuff off. So I mean, it's not CMV, it's not EBV, it's not a respiratory virus that shows up on the RVP. It's not COVID. Interestingly, I would be curious just from my future rheumatologist standpoint, obviously more common than the kiddos, but like, did she have a COVID antibody? Like, could this be a super weird MISA picture? I don't think so, but that was just something else that popped up in my brain. I mean, not Legionella. In fairness, I tried to quickly Google beta-D-glucan because I don't remember what we use that for. I think it's just a broad spectrum like fungal thing, right? So it looks like it's elevated. So I think fungal infections is still on the table. Luckily, it looks like, I mean, we didn't repeat the HIV and the TB. So I mean, that was, I'm assuming probably 2 years prior, if this is current days, 2020 or 2021. It's like those still may be, but I mean, if she was negative and hasn't had any exposure risks, probably less likely. The CT, I think, really makes this, I think, a clear-cut pulmonary. Like I'm not nearly as worried anymore, especially after that echo about a cardiac cause. I think that also helps rule that out. The ground glass opacity this is me cheating from people in the chat box. Seems like that, at least others have said that it's consistent with like a PJP type of picture. In fairness, I didn't remember that for sure. So hopefully whoever wrote that in the chat isn't wrong and misleading me. So I think that would probably be one of the top things still that I would want to make sure. And I would imagine already she's probably been empirically started on treatment for PJP with how sick she is. Like, I don't think anybody would have let her come in the door without kind of getting started on some broad spectrum antibiotics, including PJP coverage. That would probably be where I'd hang my hat on. I don't know if that's just part of the process yet, if I'm supposed to tell you what I think it is. But I also think that it could still be a strange fungal infection that they hadn't sent out stuff yet for. So I would probably like to see a fungus panel. That you can add, like fungal antibody panel. I think that's a thing. I think I've sent it once. I can't remember all of the ones that come with it. Yeah, that's where I got.
Casey, that is so brilliant. And I am right there with you. I love how you looked at, well, what are our tests? The negative tests are almost just as helpful as positive tests. And so, how do these negative tests change our differential? The one thing I would add is, just anytime I get back a negative or a positive test, I want to make sure, I want to ask myself, do I believe this? And are the test characteristics good enough for me to believe a negative test? So ×1. And so we know that there are, error confidence intervals in all of our tests. And so, for example, when we test for PJP and we use kind of expectorated sputum, we know that that's much less sensitive and specific than getting samples from a BAL, for example. And so making sure sure that we're trying to use the test that will optimize our yield. And then here, I totally agree with you. I think the imaging has essentially led us to exactly where Sherry and Anna said, which is we know we have something in the parenchyma. We're prioritizing infection at this point because that's probably the most morbid and the thing that we need to catch and treat the quickest. And then which infections, like that full spectrum of infections that Anna mentioned, are still at play. The elevated beta D glucan slightly raises our suspicion or pretest probability that this is something fungal. And to your point, I love, it's not cheating to use the chat, it's just using the hive mind of resources. And so what is beta D glucan? It is a component of fungal, often cell wall component that's also found in PJP. And so that's what we're testing for. It is not specific to PJP. So other tests that we can send include things like, so other infections that will raise your beta D glucan include other fungal infections like aspergillosis and candida, being the one specifically in a immunocompromised host, particularly post-transplant, that I'm thinking of can also elevate your beta D glucan. A more specific test for aspergillosis would be a galactomannan. So that will be really helpful. And then I do think other things that should be on our differential in someone who is post-transplant includes bacterial infections like Pseudomonas, B. cepacia. I can't ever remember how to say that bacterial name, but Pseudomonas, and then nocardia as well. Typically, nocardia and sometimes aspergillosis, you can get those like fungal balls, which we're not seeing here. We're seeing a more disseminated infection, but that doesn't rule out that that's what's at play. And so I do think we're probably headed to where, just from a respiratory standpoint, I do wonder if the patient will be intubated quite soon. And then the next steps of a BAL and sending tests off of the BAL can be really helpful. Sometimes I've heard that the sensitivity and specificity for bacterial infections is often not that good, but our fungal tests, it can be really good. That's something that I would love to hear or learn from Ashka about. But in terms of sort of empiric treatment, I would be treating extremely broadly for bacterial infections, for fungal infections, including probably double covering with maybe VORI and Ampho or itraconazole to make sure that we're getting good coverage, and then also starting PCP treatment as well. And before we get more diagnostics. And then I asked about the RVSP, which is a measure of the right ventricular systolic pressure, which often gives us a surrogate for how bad someone's pulmonary hypertension is. And you can have chambers that look really normal, but have an RVSP that's through the roof that gives us a sense that the pulmonary hypertension has gotten much, much worse. And so in someone who has known bad ILD with potentially pulmonary hypertension, who now has a superimposed infection, I would be very worried about this person because they have very little parenchymal or pulmonary reserve to begin with. And I was reminding myself for antisynthetase syndrome, it's essentially you get these autoantibodies against the aminoacyl transfer, like RNA synthetase. And some of them can have a very severe progression of their ILD. And the parenchymal imaging that we got here is for looking for infections where we didn't get a high-res CT. I don't think that's necessarily what's going on, but just will influence sort of how we think about this person and how quickly we move to treat them. And yeah, I think that's really all I have, which is essentially nothing more than, Casey, exactly what you said. I just rambled a bunch. And if I'm not mistaken, our next aliquot will reveal the diagnosis. Anna and Sherry, anything else to add?
The only thing that I'll share that I learned, that was fantastic, by the way, Casey and Smitha, is that, and I don't necessarily think this is what's going on here, but again, speaking to like the theme of, carefully evaluating the tests that we get back, I've learned that especially in immunocompromised hosts, it might take a lot longer to like fight off your more typical infections, that an upper respiratory tract like RVP or like sampling of whatever can clear long before a lower respiratory tract sampling. And so even with us having a negative RVP, I would still want to get an RVP from a BAL to confidently rule out things that can cause like a more severe pulmonary process in a patient that has a ton of pulmonary insult to begin with. And then I really loved Gerald's conversation about PCP, and the only additional like piece of information that would be helpful, while not sensitive at all, especially for a lot of like serotypes, but could maybe unify like the patient's sodium and really severe pulmonary process, would be Legionella testing, for which a BAL PCR would be much more sensitive, but it wouldn't hurt probably to send off urine studies as well. But I similarly am very interested to kind of see what data returns.
Sounds like we want a BAL with all of the fungal studies, including the endemic mycoses, testing for PCP, and Legionella, and we'll go from there. Great.
Okay. So at this point, I think ID was involved. The patient was on broad spectrum antibiotics with vancomycin as well as azithromycin. And we felt and also transplant pulmonology was also involved. And they had actually put the patient on IV methylprednisolone, and simply because they felt like this could be rejection of the transplanted lung. We took a look at the CT scan and we saw that she had diffuse infiltrates actually involving both the native and the transplanted lung. So we felt that acute rejection would be atypical, since it normally would just involve the transplanted lung. And the CT imaging was actually more concerning for PJP pneumonia. And she had been off of PJB prophylaxis with an elevated LDH as well as a positive beta D glucan. So we immediately started the patient on IV Bactrim. And the steroids, like I said, were already on board due to possible lung transplants. You guys in the beginning did ask for, some sputum samples, and then as well as a bronchoscopy later on. She did get an induced sputum for a PJP PCR prior to starting Bactrim, and unfortunately that was not detected. And a bronchoscopy was actually never done due to her tenuous respiratory status. And in reality, a few days after being on IV Bactrim, she did clinically improve and her oxygen requirement was slowly weaned. So in the end, ID as well as a transplant just assumed that this patient did have PJP pneumonia and was appropriately treated with IV Bactrim and steroids.
What a case. That was so awesome, Ashka. I really like too that how it's very realistic, and that in so many cases you kind of just have to use your clinical judgment and use the patient's clinical course to figure out in the end what the ultimate diagnosis is. And I'm really glad you're involved in the patient's care and she got the appropriate treatment that she needed. Any reflections, Smitha, Casey, Sherry?
I'd just be curious how you decide to not cover for fungal infections, and then also did they start the methylpred right off alongside of the broad spectrum antibiotics, and how do you kind of make yourself feel comfortable? Obviously we thought this was PJP, which you would give Bactrim and steroids, but how do you in that moment be I'm going to give this person who's immunocompromised, who maybe has an infection brewing, and a steroid, and then also maybe not even cover them for fungal infections? Who and how did that decision making happen? I'm just curious.
Right. So with all transplant patients, it's always kind of a conversation with the, in this case, pulmonology, transplant pulmonology. And it was really going based off of her clinical symptoms, honestly. It was more of a subacute presentation, and then also the fact that the cyclosporin, I think there was a question about the level, was low. So she outpatient transplant had been kind of tinkering with her cyclosporin and her levels were actually low. So taking that into consideration, I think pulmonology really heavily felt that this could be potentially rejection. And that was part of my differential as well. The second thing is like just looking at these patients and you know, the idea of what are they going to be at risk for? And her for not being on PJP prophylaxis was a huge concern. And that with her clinical symptoms. And then on top of that, the chest CT that we got, which showed that widespread like bilateral infiltrates, ground glass opacities, was very kind of almost characteristic of more of a PJP infection than what you would consider other fungal infections. Honestly, PJP was the biggest kind of infection that I considered. And then second would be COVID pneumonia. I think COVID pneumonia has a similar presentation with similar CT findings, but she was vaccinated. She didn't really have any exposure. She had multiple, you know, swabs that were negative. And then lastly, this pneumonitis picture, I thought CMV pneumonitis actually was part of my differential as well. I mean, her CMV DNA PCR was negative, but that doesn't necessarily mean that she could not have pneumonitis. You can have pneumonitis without viremia. So honestly, if she hadn't gotten better, I think we were all gearing, you know, towards like especially if she had gotten worse, that a bronch would be the ultimate, you know, to try to kind of differentiate what's going on, the ultimate diagnostic tool. But unfortunately, kind of, this is why I like this case so much. It's like not in IDEA specifically, we don't always have everything available to us. And you kind of have to go a lot from their clinical presentation, their risk factors more than anything. And also whatever information you do have. And the biggest things we had were that CT scan, that beta D glucan, which we couldn't ignore, being greater than 500, and most commonly with PJP, and also that LDH, which we felt like kind of tied the picture together. And fortunately for us, we were correct, and she got better. So.
Wow, this was such a humbling case, and I think really authentic. And often I think both as diagnosticians and as clinicians treating patients where we find ourselves. And so really appreciated this discussion, and just absolutely blown away, Casey and Sherry, by both of you all and your discussion and just your willingness to put yourself in this lukewarm seat. I learned so much. Similar to Anna, we don't frequently take care of patients who are post-transplant. And so getting to kind of apply a very common chief complaint to a very uncommon past medical history is a super, super helpful learning experience. So thank you all so much. Again, this is such a special hour for us as the WDX VMR, a space that we try to elevate women's voices in medicine. And so if this is something that you would be interested in or want to learn more about, please do reach out to us. We would love to have you. And with that, we will turn it over to Gorleen for our teaching points, I believe. And then Sherry, if you have any other thoughts, would love to hear from you as well.
I just want to say thank you, Ashka, for presenting this amazing case, and Smitha and Casey for discussing. I learned a lot, and one thing like Anna and Smitha taught us is like really thinking about the test characteristic when interpreting lab values. So I will keep in mind. Thank you.
Yeah, this was such a great case, and I learned so much from everyone's discussion. So just to recap some of the teaching points from this case. So when we first presented with this patient, the main concern was the Dysmeon exertion. So when we're approaching Dysmeon exertion, we can think about it in an anatomic way. We can think about the cardiovascular system, thinking about, is it something in the myocardium, the pericardium, or the electrical system causing the dyspnea? So when thinking about myocardium, thinking about things such as heart failure, acute coronary syndromes, or valvular issues, thinking about the pericardium like tamponade or constrictive diseases, and then arrhythmias in the electrical bucket. And then thinking about the pulmonary cause, we can also divide it based on anatomy. We can think about the airways, things such as bronchiectasis or asthma, kind of layering on what the patient's baseline conditions are. Other things to keep in mind, we talked about vasculature, thinking about things like pulmonary embolism or vasculitis or other things like pulmonary hypertension. And then also keeping in mind like parenchymal causes of Dysmeon Exertion or things in the alveoli if there is water, blood, or pus, something filling up the alveoli, which is leading to the difficulty breathing. And then always considering other causes as well, things like chest wall disorders, things like anxiety, thyroid conditions, or anemia leading to dyspnea. And then the main thing is the time course as well as who the patient is and layering on the symptoms. In this case, there was the dry cough and the hypoxia. So we were thinking more in the pulmonary system. That's where we were localizing it. And then in this case, the patient had this baseline interstitial lung disease and the lung transplant. So when we're clinically reasoning through cases like these, the main concern is this current presentation an extension of the pre-existing condition, like an acute on chronic worsening of the interstitial lung disease, or is this a new entity? So that's the important thing to sort out. And then when we're approaching a patient that's status post-transplant, we need to prioritize infection because of the immunocompromised nature with the immunosuppressive medications. And when we're thinking through different buckets, we can think about viruses that we're considering like HSV, VZV, CMV, as well as atypical bacteria, asking about exposures and kind of broadening our differential when we're thinking about things. And also fungal infections and parasites will also be things to consider. And when we're prioritizing infection, it's also important to remember that you can't forget other things. So when someone is status post-transplant, thinking about things such as rejection, as well as side effects for medications and other things, but also keeping other things in mind as well, unrelated conditions to the transplant. And then thinking about steroid use, certain infections might be more likely in patients who are chronically on steroids, and those would include PJP, crypto, aspergillosis, mucor, or candida. And then in this case, the lab values and physical exam were also important to collect the different clues and figure out, kind of narrow down our different possibilities. So elevated LDH does point towards PJP. It has high sensitivity but low specificity. And then the other thing we mentioned was using the physical exam to kind of localize where the process is happening. In this case, most of the physical exam was localizing to the lungs, so really thinking about that. But also keeping in mind that people who are immunocompromised or have other things, their signal might be masked, so it's still important to send out all the important labs and not just rely on things that were abnormal in the physical exam. And then the other lab test that we talked about was the positive beta-D glucan, and this is something found in the cell wall of fungi and also in PJP, but it's not found in certain fungi such as mucor, crypto, and blasto. Other things that the chat talked about were false positives for beta-D glucan. So to keep things in mind, like nocardia, pseudomonas, they can cause false positive, as well as some other bacterial organisms. And then the final diagnosis was a PJP. So when we're thinking about an illness script for PJP, we're thinking about who does it usually affect. So it's usually immunocompromised people, HIV if they have CD4 counts less than 200, but also people, in this case, like status post-transplant on immunosuppressive medications. And then what the clinical syndrome is. So it's usually dyspnea with possible fever, and then the high LDH and the beta-D glucan. And usually chest x-ray shows bilateral interstitial infiltrates, and CT scans show ground glass opacities. Usually there's, I think the traditional illness script is usually there's no pleural effusions. And then when we're diagnosing PJP, it's important to remember that induced sputum can miss the diagnosis, but bronchoalveolar lavage is more sensitive. And I think, as Sherry was mentioning, I think a key takeaway for me was when a test is negative, it's important to understand the test characteristics for the test you're ordering and use that to guide your further diagnosis, because you can still miss diagnoses if something is negative. So thank you everyone for joining us, and this was such a wonderful case. Thank you.
Erlene, that was absolutely masterful. And just want to say it's so hard to track the discussion that's happening and then also include pearls from the chat. And you have organized them and taught us so much. So thank you. That was brilliant. Thank you all. Casey, Sherry, thank you for joining us. And Asha, this was such a wonderful case. Thank you so much for joining us. And we hope to have you join us again in the future and learn from you. We'll open it up for any last reflections, but if not, thank you all for joining us, and we will see you again for another WDX VMR in a month. Thanks, everyone.